I now bring this meeting back into session. This is the 11th meeting of the COVID-19 Committee in 2021. This morning, the committee has already considered its legacy report under agenda item 1 in private, so we will now move to our second agenda item. I should advise that we have received apologies from Stuart McMillan MSP, who is attending another parliamentary committee this morning. And I welcome Emma Harper MSP to this meeting, who is substituting for Stuart. Emma, do you have any relevant interest to declare?
Yes, thank you, Convener. Good morning, everybody. It's probably relevant that I declare that I am a registered nurse and I'm currently part of NHS Dumfries and Galloway's COVID vaccination team.
Thank you, Emma. We will now move on to agenda item 2, subordinate legislation. This morning we will be taking evidence from Michael Russell, Cabinet Secretary for the Constitution, Europe and External Affairs, Professor Jason Leach, National Clinical Director, and Dominic Munro, Director, Exit Strategy from the Scottish Government. This session gives members the opportunity to take evidence on this week's first ministerial statement on COVID-19. The committee will also consider the following regulations: the Health Protection Coronavirus Restrictions and Requirements Miscellaneous Amendment Scotland No. 2 Regulations 2021, SSI 2021/117. Cabinet Secretary, can I welcome you again to the meeting, and can I invite you to make a brief opening statement?
Thank you, Convener, and thank you for the opportunity to attend this meeting again. I think it's the 25th time I have given evidence to this committee, and this will also, I think, be the last committee which I will give evidence to in the current session and indeed in my parliamentary career. Can I thank you for the opportunity to update the committee. The First Minister on Tuesday set out the details of our next steps out of lockdown. Delivering on these plans is dependent upon continued progress in suppressing the virus and rolling out vaccines, and I want to make that very clear. I can confirm that we expect to lift the current stay-at-home rule on the 2nd of April. From the 5th of April, we expect contact sports for 12 to 17-year-olds to resume. We also expect more students to be allowed to return to on-campus learning. We plan to begin the phased reopening of non-essential retail. By the middle of April, again supplies permitting, we will have offered first doses of the vaccine to all 9 priority groups identified by the Joint Committee on Vaccination and Immunisation. Reaching that milestone will give us confidence to move all parts of Scotland currently in level 4 down to level 3. The island communities currently in level 3 can move at that stage to level 2. However, we intend to discuss that with those communities as it has implications, and indeed and Beatrice Wishart will be in the same position. I've already had substantial representations on that matter. We expect that from the 26th of April, restrictions on journeys within mainland Scotland will be lifted entirely. On the 26th of April, we expect all remaining retail premises to reopen, as well as all tourist accommodation, libraries, museums and galleries, indoor gyms for individual exercise, work in people's homes and driving lessons. And we expect that the limit of attendance at weddings, funerals and associated receptions will be raised to 50 people from the 26th of April. Also from that date, 6 people from up to 3 households will be able to meet outdoors, and 12 to 17-year-olds will be able to meet outdoors with up to 6 people from 6 households. The hospitality sector will also begin to reopen from that date, and people on the shielding list can return to work. Children and young people on the shielding list can return to school or nursery, and students on the shielding list can return to college or university. From the 17th of May, indoor hospitality will continue the return to greater normality. Adult outdoor contact sports and indoor group exercises will resume, and cinemas, amusement arcades and bingo halls will reopen. We also hope outdoor and indoor events will restart, and colleges and universities will turn to a more blended model of learning. Further face-to-face support will also resume, as will non-professional performance arts, and we expect restrictions on outdoor social gatherings to ease further. From that point, it becomes much less certain, but we have given an indication of what may be possible following the 17th of May. That is heavily dependent on the data, and final decisions will, of course, be taken nearer to the time. Finally, Convener, the Health Protection Coronavirus Restrictions and Requirements Miscellaneous Amendments Scotland No. 2 Regulation 2021 are also on today's agenda. These regulations amend the Health Protection Coronavirus Restrictions and Requirements Local Level Scotland Regulations 2020 to make what are a few technical adjustments. They remove festive gatherings, as they have now served their purpose, and adjust end-of-term households so they remain fit for purpose now that the term 2 has begun. These regulations also adjust the definition of professional sportsperson and clarify that only those persons and performers can access indoor fitness, such as gyms. In addition, these regulations also remove the requirement for child contact centres to close in level 4 areas. Guidance sets out when and how they can safely be used. The regulations also ease the restriction on libraries to ensure they can open for the purpose of providing free computer and internet access where an appointment has been booked. These regulations also extend the expiry date of the Health Protection Coronavirus Restrictions and Requirements Local Level Scotland Regulation 2020 and Health Protection Coronavirus Restrictions Directions by Local Authorities Scotland Regulations 2020 to the 30th of September 2021. It is clear that we are not yet in a position to allow this legislation to expire. They will be kept under regular review and will be relaxed or revoked when appropriate. These regulations were made on the 4th of March and came into force on the 5th of March. And Convener, I hope that committee has found that explanation helpful, and of course I'm happy to take questions along with my colleagues Jason Leach and Dominic Munro.
Thank you very much, Cabinet Secretary. That is, as ever, very useful. Can I now turn to questions and remind members that we have approximately 8 minutes each for questions, so it would be helpful if we could keep questions and answers concise. I think my first question is really for Jason Leach, the National Clinical Director, and it's about the news that vaccine supplies into the UK are facing a significant reduction from the 29th of March due to international supply chain issues. Will that affect the mid-April target to vaccinate all those in the JCVI priority groups in Scotland? And what does it mean for the wider rollout to the adult population?
Thank you, Convener, and good morning, everybody. It feels like a bit of a moment to be Mr Russell's final ever parliamentary committee in his present role, so it feels like a bit of a privilege. So thank you, Mr Russell, for the education you've given me on how to be at these committees. I will endeavour to continue that, because I unfortunately don't get to leave. The answer to your question, Mr Cameron, is in simple form, we do not today believe it will affect the mid-April target or the end of July target, but it is a significant reduction across the whole of the UK, and we will feel that proportionately, just as Northern Ireland, Wales and England will as well. It is exactly how the system is meant to work. We check all the batches, we have a massive global supply chain from these companies, and we always said, you were fed up with us saying that everything was supply dependent. We have modelled as much as we can. We're still seeking some clarity on the exact numbers, and the Cabinet Secretary for Health will update MSPs in Parliament just as soon as she can. Our present understanding is we can still meet the mid-April offer everybody in the top 9 groups a vaccine, a first dose, and we can still meet our end of July target for the whole adult population. But it will inevitably mean that after the top 9, we will just have to think about who comes next and when they come next.
As a follow-up to that, can I ask about the issue of second doses, and how does that fit into provision of second doses?
Yeah, so we again, as of today, we do not anticipate it affecting our second doses at all, because we can prioritise them. And just now, they are mainly Pfizer, because Pfizer came first, if you recall. We got Pfizer first. We did care homes, we did the over 80s in the main with Pfizer, not entirely, but mainly, and we have Pfizer. The other important thing is that there is no suggestion from either company that the end point number is any different. It's about the lumpiness of the supply. It's not about the total supply. So it's not that we're suddenly not going to get 5 million doses. It's that the 5 million doses are going to come in slightly lumpier form than we expected. So we're as confident as we can be today. That of course could change. We need to keep the modelling and all of the data under daily review, and we have teams of people doing that even this morning, following yesterday's news in particular. We're confident that second doses will not be affected in terms of their 12-week target.
Thank you for those answers. That's very helpful. I'd like to move on to the new framework announced on Tuesday. From what the First Minister said, it appears that we are moving out of lockdown at a national pace. Does that mean that there is no scope for a local easing of restrictions, given that the level system appeared to work well and allowed local circumstances to be taken into account?
No, it doesn't mean that, but it does mean that it is a step at a time. I think quite clearly local considerations and local outbreaks it would be taken very seriously, and it would be possible, for example, to move backwards, if there was a deterioration of the situation in one part of Scotland. So that flexibility has remained, and indeed, we're renewing those. I hope we're renewing those regulations today. But we do require to think about the experience that we had last year to improve upon the system, which we felt worked reasonably well, but could always work better. And that's what we're trying to do. And there are some issues arising with islands. For example, in my own constituency of Argyll and Bute, there are islands presently at level 3, but most of the areas at level 4, most of the mainland and a couple of larger islands are at level 4. So how we actually manage that situation is a matter that we need very careful thought about. And indeed, I've been engaged in that today, and others will be engaged in it over the next few days to try and get that right. So I think broadly, the level system will come back. We hope to be able to move as a nation, but there will be flexibility within it.
Thank you for that. My final question is more of a technical one, and it's to the Cabinet Secretary. Can you advise how the Scottish Government will operate secondary legislation during the pre-election period, given that some SSIs are, of course, time limited? Will there be any informal mechanism of updating Parliament or this committee as to any relevant secondary legislation laid before dissolution on May the 4th?
Yes, and I think I have already made clear to you, Convener, that the issue of reporting, we will publish the next report, which is due at the end of this month on the 14th of April. We can't lay it because the office of the clerk is closed. We can, of course, deal with emergency legislation, and secondary legislation may have to. But I think I said some weeks ago at this committee, and I'm happy to confirm again here, subject to the decisions of the Parliamentary Bureau, and I'm sure the Bureau will consult you and the committee on this, I am happy to make myself available to the committee at any time, should there be a need to do so, in terms both of secondary legislation and other developments. And I'm sure the First Minister will be making contributions in terms of what the situation is during the period of what I think we now officially have to call election recess, because the Parliament is not dissolving formally, but it is essentially a dissolution that is taking place, but with the flexibility to continue to operate if we need to. Very mindful there needs to be scrutiny of the regulations. I am more than prepared to come before this committee or any part of the Parliament to explain and to talk about the regulations.
Thank you for that. I now turn to the Deputy Convener, Monica Lennon, for her question. Monica.
Good morning. Thanks, Convener. Good morning, Cabinet Secretary. On the regulations, my question was about, as the regulations seek to extend the principal regulations until the end of September of this year, can I ask why a full business and regulatory impact assessment, equality impact assessment and fairer Scotland impact assessments haven't been carried out?
Because the intention of the regulations remains the same, and quite clearly, we would carry it out when we felt the policy intention of the regulations had changed. I'm very happy to, look at that again, to speak to officials about it again, and if there is any view, and if you have any view that it has changed, then we'll factor that in. But what we're doing here is essentially a technical move to make sure that we do not have a hiatus, and I think we would all agree that hiatus would not be a good idea.
Thank you. Perhaps there will be scope for some further discussion on that. I've only got about 7 minutes, so can I maybe switch now to vaccines? The convener's covered some ground already. This is perhaps more an operational matter, perhaps for Professor Leach this morning. I won't go over the dozens of examples that I've had sent to my inbox and what I've seen also on social media, but there seems to be a situation where people have not had appointments. They've been advised by friends and colleagues to phone the COVID contact centre, and when they do, lo and behold, they get an appointment. So just this morning, 2 of my constituents who live in Hamilton, they're both 58 years of age, they were advised by a friend to phone up. They did so, and they now both have appointments for next week, which is great. But does this mean that the system is working well? Is that the way we would want this to work, that people just randomly phone up? Maybe try and talk us through that and how we can improve on it.
Well, I'll pass that to Jason Leach, but it does seem to me that you have said, when people phone up, they get an appointment. I think that is good news. But Jason, no doubt, will want to add to it.
Thank you, Ms Lennon. Only to say the only systematic challenge that we know of was one in Lothian, which we discussed earlier in the week and resolved Friday, Saturday, Sunday, and that was a problem with some letters not going out. Those 2 examples in Lanarkshire you've given, I imagine, I can't know for sure, their letters will arrive on their doorsteps prior to their appointments. The challenge here, partly in relation to the supply question Mr Cameron asked me, is we have to match the supply as it comes in. We don't want to cancel appointments, so therefore the appointments are inevitably at short notice. And your letter is probably in the mail, you phone up and somebody looks at the screen and says, yep, you have an appointment for next Thursday, but your letter will come tomorrow, or perhaps on Saturday, or perhaps even just 2 or 3 days before it. But it's a factor of supply, and the health boards are doing their absolute best to give as much notice as we can, but we don't want gaps. We don't want days with fewer vaccines than we have. So it means that some of those appointments are short notice. So I would ask people to be patient. Don't phone the helpline for a reason that's just because you haven't. So I could phone, I'm 52, I could phone and say, where's my appointment? I won't. I'll wait for that appointment to come in the mail.
So if you did make that phone call, Professor Leach, or someone made that phone call, are they likely to get an appointment? Because this is what's happening. People are seeing friends on social media doing this. I've had examples this morning. So I suppose what I'm saying is those who are maybe, better informed will make the phone call and get an appointment. Is that the way it should be working? That's
not what's happening. People are phoning. They are being told the appointment they already have. They're not being made an appointment. So they are phoning up the helpline. The helpline is saying, yes, you have a scheduled appointment for next Thursday at 10 o'clock at the Louisa Jordan at Airdrie Town Hall, and that letter will be arriving. They are not jumping the queue.
So just to be clear, the issue is about the speed of the letter reaching the individual through the letterbox.
That's my understanding of the issue. If you have other news and other stories, as my inbox has them, then I'm very happy to get the vaccine teams to look into them specifically. But the problem in Lothian was exactly as I've just described, and there are occasional ones around the rest of the country as the Royal Mail endeavours to help us as much as it can to get those letters out on time. But inevitably, some people will get a letter today for an appointment on Monday, for example, and we'd much rather give more notice than that. But because of supply, we have to hold them back until we're sure we've got vaccine, then send the letters, and then people come for their appointments.
Excellent. Well, I do have family members getting the vaccine on Saturday in East Kilbride, which is great news. So obviously we want people to get their letters and to get their appointments. I'll move on then. Just a couple of things after the First Minister's announcement. Again, it might be better for Professor Leach to answer. And whilst with lots of good news and lots of clarity for some sectors, MSPs have been getting inundated with emails from some quarters. Can I ask for some clarity on baby and parent classes, when they can operate again and under what terms? And in particular, I seem to be getting lots of queries about dance classes for children, and some anxious parents who've got children who are due to be in competition. And just a final point on that, about retail. Baby clothes shops have been able to operate under click and collect, but I've had a few local inquiries from retailers who don't know if they have to wait until the 26th of April or they can open on the 5th of April. And they said that previously there's been an anomaly where garden centres could open who sell baby clothes, but they couldn't open their shops. So just maybe get some clarity on that, and if not now, maybe in writing later.
I think Dominic Munro can probably address those points because he has has been involved in detail of this. But from my own memory, and he will either correct or contradict me, I think baby clothes shops can reopen in early April. But perhaps Dominic Munro could do that.
Yes, thanks. And Ms Lennon, very happy to take up your offer to provide this information in writing, as there's quite a bit of detail in this. And the other thing to note is that we are planning to bring out more detail, setting out the details across our levels framework in the next few days or so that a lot of these questions can be answered with greater clarity. So more retailers and click and collect are indeed scheduled to open on the 5th of April. And I would suggest that we kind of set out the specific details on baby and parent classes and dance classes for children in writing. And partly that's because there'll be different restrictions lifting at different times, depending on whether we're talking about 12 to 17-year-olds or potentially children under that age group, and depending on whether it's indoor or outdoor and so on. So if it's okay, Ms Lennon, these are really good questions, and we'll set out that writing in writing as soon as possible, ideally today. Thank you.
Thank you, Dominic. That would be really, really helpful. Thank you, Convener.
Thank you, Monica. Our next questions come from Beatrice Wishart. Beatrice.
Thanks, Convener, and good morning, Cabinet Secretary and Professor Leach. Cabinet Secretary, in your opening remarks, you mentioned island communities, and while people on mainland Scotland now have indicative dates for the easing of restrictions, can you provide more information on the discussions and engagement that the First Minister said would now happen for our communities in the islands, and to establish how levels might be adjusted, because there is great uncertainty? The leader of Shetland Islands Council is quoted in local media today as saying that there is, quote, no clarity around this, and rather worryingly he indicates that there's been no communication with the Scottish Government since Christmas. Can you provide any more detail?
I can't comment on that because I have no knowledge of that, but I can say very clearly that the intention that the First Minister announced, I think, should be warmly welcomed, that rather than imposing a solution on the island communities should have the opportunity to participate and to make clear their views and what they wish to do. I'm an island, I represent a lot of islands, so do you, Beatrice Wishart, and we know, you will know, that there have been a lot of inquiries about this in the last 24 hours. It is important that the local authorities are involved. It's important that communities are involved, through community councils or other groups. It is important this takes place speedily so that there is a quick resolution and people understand what's going to take place. But broadly, the principles that apply to this should be clear. First of all, there should be a wide-ranging consultation and people should be able to say what they want. Secondly, the principle of equity should apply, that people should be treated fairly. Thirdly, there should be no disadvantage for island communities, and that final point is very important in terms of travel backwards and forwards. People want to see their families in other areas, quite clearly. It'd be wrong that if others were able to do so in Scotland, they couldn't do so. They also wish to be able to reopen hospitality and to reopen tourism, and it would be unfair if they were not able to do so as well. There is, however, the issue of spread into island communities, which can be particularly difficult, as we've seen on a number of occasions during the pandemic. So all those things need to be discussed and debated. I don't think there's any intention not to be clear. There's an intention to try and get as much view and information as possible and to put that alongside the science and the data and to come to a conclusion that benefits island communities. And that's what we're endeavouring to do.
Thank you for that. That would be helpful to know that there is some speedy resolution to finding how we go forward. My next question would be to Professor Leach. Professor Leach, can you give an update on reports that the number of COVID cases are increasing on North Sea oil installations? My understanding is that most companies test employees before they head out to the rigs, so an understanding of the position would be useful.
I have nothing specific. I'm very happy to look into it. I get an outbreak management report once or twice a day, and there are occasional positive cases offshore, inevitably, because testing can only stop so many. People could be incubating. But the oil companies in the round have been very good at managed isolation long before we had it as 4 UK countries, and they've done testing from the very beginning, often privately, and now more incorporated into our overall system. So I don't have any specific intelligence that has worried me in the last couple of weeks, Ms Wishart. If you have something specific, I'm happy to look. If not, I will look anyway, just to make sure we're not missing anything, but I've got nothing new.
That's comforting, actually, and yes, I know that they have been working very hard from the beginning to make sure that their employees were kept safe. My final question is a very brief one. Will congregations be able to sing together by Easter?
No, they will not, I'm afraid, much to very, very many people's disappointment.
Thank you for the clarity. Thank you, Convener.
Thank you, Beatrice. We turn next to Willie Coffey. Willie.
Thanks very much, Donald. Just a couple of questions from me again. Perhaps the first one to the Cabinet Secretary. And firstly, thanks, of course, Mike, for all your hard work and service on behalf of the Parliament and the party over many years. I wanted to put that on record to thank you about it. As usual, Mike, with the change in regulations, I've been inundated with local constituent inquiries from the hairdresser, barber and beauty salon sectors. As you know, the hairdressers, barbers can reopen on the 5th, but the beauty salons and so on are being held back until the 26th. I wonder if you could just tell us a little bit of your thinking about why we would differentiate between the two groups to have such a gap in the reopening for both of those types of business.
Thank you for your kind words. Not everything can reopen at once. I mean, if you step back from this and look at it and say there is a risk in reopening anything, because quite clearly, transmission can start again, and therefore, if you're endeavouring to keep the virus suppressed and to suppress it further, you have to take a staged approach to this. Therefore, I think there's been huge keenness to see hairdressers and barbers reopen. I'm very keen myself. I'm grateful to my wife who has cut my hair twice, but I don't think she wants to do it a third time. As a result of which, there is a desperate keenness for that to happen. I am sure people wish to go to beauty salons too. Regrettably, some things can't happen. Not everything can happen at the same time. It's just as logical as that.
Is there any reason that, I wonder if Jason might answer that? I mean, the amount of time now, I'm not speaking from personal experience here, but the amount of time I'm told that a person may spend in close contact at the hairdresser is much greater than the amount of time in close contact at the beauty salons and therapy salons and so on. So it seems to my constituents that we've kind of perhaps got it around the wrong way there. Is there a case to answer there, Jason?
I think Mr Russell is... Hi, good morning, Mr Coffey. I think Mr Russell's right. It's not a matter of why can't you have A and B? You can only have one. It's as simple as that. And it's more complex than that, of course, because you're trying to do 15 things and not have another 45 things. So it's very simple decision-making, but complex. So the decision makers have decided that barbers and hairdressers should go back 3 weeks earlier. And there's a batch of things going back on the 5th and a batch of things going back, we hope, on the 26th. And we need that 3 week period in order to show what happens to the numbers. It's a matter of coverage. It's a matter of business support. It's all of those things are done in the advice that goes to Cabinet, and then Cabinet makes those choices. But the beauty business is correct. They have good mitigations in place. It's not a reflection on their ability to manage as safely as they can, but nothing can open entirely safely. Everything is risk. Travel, gathering, the event itself, travelling back, everything that goes on around anything that's open. So it's not, I'm afraid, just as straightforward as the individual business putting in place mitigation, which the beauty therapy business has done.
Mm-hmm. Thank you for that. And my last question, probably to yourself, Jason, it's about testing. You look at yesterday's data, we reported 625 positive tests, and that's 3%. That tells me that we tested about 20,800 people. It's just to ask you about the changing pattern of who is actually being tested. What's the testing cohort looking like now? Is it principally younger people because older people have now been vaccinated? Do we still test people who have been vaccinated? Could you give us a little flavour, please, of who is in the testing cohort now?
Well, remember the PCR testing, the top end of our testing regime, which requires a laboratory. You can't do it in your house. You can't do it in the school. You have to have a laboratory, and it takes around 24 hours to get the results back. That is driven by people with symptoms. That is still driven by people with symptoms, or people who test and protect tell to go and get a test. Seeking asymptomatic cases, for instance, in a household or in a set of contacts, depending on the circumstances of the original index case, which is usually a case with symptoms. So that number of tests done proportionately has fallen because we don't have as many people with symptoms. We still have too many, but we don't have as many as we had in January when we were doing 2,000 cases a day rather than 600 or 700 cases a day. And the positivity rate, some people don't like the way we are doing positivity. There's a variety of ways of doing it. Ours is, you're right, just a simple fraction. It's the number of tests, it's the number of positives divided by the number of tests. So, no, the other way around. I was right. I got it right the first time. My arithmetic let me down. It's the number of tests divided by the number of positives. And that gives you that number. So that does give you a rough idea of how we're using symptomatic testing or contact tracing testing. And we're very comfortable with how that is working. The turnaround time is good. The turnaround time to contacts is good. The other big piece that is much newer is the lateral flow testing done in high-risk environments, let's call it. Started in care homes, then moved into schools, then moved into other workplaces. And the testing strategy announced this week expands that further. Local authorities can call on both of those types of testing, should they require them, according to their public health advice that they get from their local directors of public health. And then the final thing I would add in the testing strategy, I think this is crucial, and it won't help us tomorrow, but it will help us going forward, is an expansion of the genomic testing ability, which is the very high end where we can find out which actual mutation, which version of the virus an individual has. And we don't have much of that in Scotland yet. We have it across the UK at a high level, but we're going to develop it in Scotland so that we can manage that, some of that ourselves.
Just finally on the age profile, though, is it mostly younger age groups coming forward now because older people have been vaccinated?
I'd have to look at the actual numbers. My understanding is it's mainly working age people, and that's where we're getting the positives, and that's where we're doing the testing, because it's people who are out and about a bit more, who are more likely to interact, and therefore more likely to catch the virus. The answer to your basic question of do you test if you've had a vaccine? Yes. So if somebody has symptoms, or Test and Protect call and ask all the contacts to be tested, then we absolutely test. Vaccine is not foolproof. Some people will not be protected, and some people will not be protected yet because of the time it takes for immunity to develop.
Okay, thank you very much for that, both of you. Thanks. Back to you, convener.
Thank you, Willie. Our next questions come from Mark Ruskell. Mark.
Yeah, thanks, convener, and morning to you all. I'm just thinking about the next 2.5 months ahead, because we're going to have a bit of a gap now in terms of regular parliamentary scrutiny, and I appreciate what the Cabinet Secretary, what you said again this morning, which is that you'd be prepared to come to this committee if needed during a recess. I think that's very welcome. But I'm just thinking about what issues may emerge in the next 2.5 months that you will have to. And if I could just take a couple of these in the short time that I've got, just to get your reflections on. I mean, one could be around gaps in vaccine delivery. So I think we're already seeing a little bit of a divergence with urban areas falling behind rural areas in Scotland, particularly the islands. There may well be a situation where we have a lack of delivery, perhaps with low-income communities or BME communities as well. What will you do in that situation? Because you don't currently have JCVI advice to guide you on that.
I think Jason should answer that. I mean, he deals with the issues of vaccination.
So I think in general terms, Mr. Ruskell, I and my unelected colleagues we'll be very comfortable in updating whoever asks us, whether that's in a media sense or in a parliamentary sense, or simply the convener or the clerks writing to us and asking us questions. I will be fully available for factual public health advice during the pre-election period. That will not change. And I would expect my answers to you today to be the same answers I can give you 2 or 3 weeks from now and 8 weeks from now, wherever we are. And we are available to Mr Cameron, to you, to others during that process. That will have to be, of course, be managed, but the public health advice is not going away. And I think we do have to think carefully about how that public health advice is given, both to you, because you're an important transmitter of that information to your constituents, along with all your colleagues, and to the public at large. And we're thinking about how we do that just now. The specifics of your question are absolutely right. The JCVI have said something about that. They've said to prioritise by age, but they've said to ensure you have a programme that reaches groups that don't naturally come towards the health service. They don't quite put it like that. And we have exactly that. We have third sector, NHS, social care partnerships, which are reaching out to our homeless, reaching out to our BAME communities with trusted voices, and all of that will continue. If we see large gaps, large percentage drops in some communities, we can adapt to go where some of that is. And one of the things we will now do at the end of the 1 to 9 group is we will have to make sure we've given people as much opportunity as we can to come, whether they are gypsy travellers or whether they're in very tightly dense urban populations, and we will do that. There will, of course, be variation. It's somewhat easier with big batches to do Shetland all at once, or to do more in Shetland than it is to do in Sauchiehall Street. So there will be variations in there. And I would anticipate that smoothing out over time, but equally happy to come back here and discuss it.
Okay. The other aspect for that is that I recognise there's some data at the moment that's showing, particularly amongst healthcare workers, the vaccine is resulting in a reduction in transmission. Do you think that could help to change the vaccine strategy as well, and really sort of refocus again on particular occupations where transmission is a factor?
It's a terrific study. It's brand new. It's the first of its kind, and what for those watching, what it suggests is 300,000 healthcare workers. If you live with a vaccinated healthcare worker, you're 30% less likely to be infected. If you live with a vaccinated healthcare worker who's had 2 doses, you're 54% less likely to be infected. So it is one of the first studies in the world proving that transmission is reduced. It's early days though, and it's only one study of, I think, only 2 in the global literature about COVID vaccination transmission. And the Joint Committee will, of course, look at it. Their present advice, and I think this will stay in place while we go fast, is to go through the ages just as quickly as you can. I think that might change, Mr Ruskell, as I've said to you before. I think that might change in a booster version of vaccine in autumn, winter. There may be different choices made when we have millions of doses available and we can make different judgments. But for now, the best way to save lives and to stop hospitalisations is to work our way through the age groups.
Okay, thanks for that. The other key point, of course, will be what happens after the 26th of April. If there's a resumption of travel within the UK, if there's a resumption in international travel as well. I mean, how prepared are you to really prevent new strains of virus, variants of concern, from coming into this country or coming into England, other parts of the UK, and then spreading Scotland? What will be the conversation with the aviation industry in the next couple of months, should we get to a point where international travel is opening up again?
Well, I think the First Minister has been very clear, and I would want to be very clear, that we don't anticipate international travel opening up, within that timescale. Quite clearly, we will be determined to continue to have a policy which prevents new variants entering, or if they do enter, they are able to be dealt with very quickly. So the issue of international travel will require to be resolved, and is not resolved as yet. Non-essential international travel is not on the agenda for some considerable time, and I think we all have to accept that.
Okay, thanks. My final question is about testing, and we obviously have the statement from Minister Marie Goujon yesterday, and I asked her really about, whether there's a case for particular occupations, particular workplaces that you could say at this point are high risk because there have been outbreaks, seeing the rollout of asymptomatic testing capacity, so beyond the food production facilities, beyond the care homes and the schools that already are receiving that testing. I think the answer I got was that this is really for health boards to work out. Can you explain a bit more about how that will now roll out? Because I'm still seeing workplaces within my region that are not covered by the current policy. They're not covered by asymptomatic testing, but I'm still seeing outbreaks. I'm still seeing potentially high risk workplaces which are not getting this testing capacity, and it's not really clear how that's going to evolve in the next couple of months.
I think Jason should address that.
I think there's three levels to answer that question, Mr. Ruskell. I think there's a national decision about high-risk workplaces. So we have chosen, with national public health advice from Public Health Scotland, the National Incident Management Team, to say we're going to do asymptomatic testing in schools, universities and colleges, food production warehouses, etc. So there's some that are national decisions. And we could add to that list if we see a pattern of national outbreaks in specific workplace types, call centres, civil service offices, whatever, inside there. We could add to that national programme, for sure. Just now, we're comfortable with what we've got, but that can, of course, change. It has changed before. The second level is local authority and NHS advice locally, so perhaps your constituency, perhaps the Cooper Angus chicken factory, perhaps a call centre in North Lanarkshire, where we can move asymptomatic and or symptomatic testing, PCR testing, into help with that outbreak. And if there were a theme in an area, the public health leaders there could call on that testing at very short notice to help with it. And then right at the end, there is very local individual workplaces asking for help, and they can absolutely do that. And there's routes into health workers, public health workers, but also to environmental health workers inside there who can access testing. We have capacity to help them whenever they need it.
So that's any workplace then?
Sorry, Mark, I'm sorry to abbreviate this, but I think we have to move on now. Can I move next to John Mason, please?
Thanks very much, Convener. And we've been told that there's an increasing number of cases in some local authority areas. I think South Ayrshire has been mentioned. And I just wonder if there's any thinking as to why that has been happening. I mean, we've also had, obviously, the schools have gone back fairly recently, and we've had large gatherings in some cases. And I wonder if there's any connection between all of these.
I think Jason should address this.
Yeah, I was just bringing up the numbers. South Ayrshire has got the largest increase in the last 7 days. It's now at 122 per 100,000 on the latest data I have, closely followed by Renfrewshire, which has gone up 49 in the last 7 days. Now, I should balance this with the fact that most places have come down and most places look at least stable or falling. So, for instance, Clackmannanshire, which we've spoken about here a number of times, in the last 7 days has come down to 56 from well over 100. So it is possible at this level of prevalence to get down quite quickly if you can get a control of those last few cases in your environment. I've got no specific intelligence about South Ayrshire. There is more open. I mean, the schools, early learning, adults are gathering. There is more open, and we expect more transmission as a result of more being open. And it will be not one thing, it will be all of that together. We have no specific intelligence that says mass gatherings last weekend, for example, or the weekend before now, have led specifically to outbreaks in Lanarkshire. We do have a few test and protect cases of positive cases who were at mass gatherings, as we've said this week, but we've got nothing specific of large-scale outbreaks as a result of those activities.
Okay, thank you. So I don't know if this is more for Mike Russell, but I mean, I just wonder where we're going with mass gatherings, because we are due to have a Rangers Celtic game this weekend. We understand that the subway frequency is going to be increased because more people are expected to be travelling for the football, and yet that goes straight against all of the advice. So, I mean, is the game going ahead, and how can we control the crowds?
Well, I think that is a matter for Humza Yousaf to comment on, not me. He's made it clear at the present moment that football clubs have been taking necessary action to make sure that people do not break the law, and the police have made it clear that breaking the law will be cracked down on. So I think that is where we are at the moment. But I really think that is a matter that Humza will have to address over the next period, and I don't think I'm in a position to do so. But I'll try and make sure that he clarifies that with you. It is absolutely clear that mass gatherings should not take place. The regulations still say people should stay at home. That is the regulation. And that is the situation in which we are. That will change. We will move from that in early April, when people will be allowed to move about a bit more. But if the situation is don't leave home, then you can't have, by definition, a mass gathering. That's not going to take place. So that remains the law. I don't know if Dominic wants to say anything about that.
No, nothing further to add, Mr. Russell, just exactly as you've said.
Okay, well, thanks very much. And on a completely different subject, the suggestion has been that we are increasing the amount of genome sequencing considerably to, I think, 1,000 a day has been mentioned. And it's also been suggested that, I think, as Iceland does, we could almost test every person who tested positive, and that would help to know whether cases were coming in from other countries or from here. It's not an area I know a huge amount about, but maybe Professor Leach could kind of explain a bit more what's happening in this regard.
Yeah, a couple of things, Mr. Mason. So we can presently test 25,000 a week to the genome sequencing level across the whole of the UK, and the UK has a coalition of higher education institutes that do this on behalf of all 4 countries. If you get your prevalence down to 25,000 cases a week, you can test them all genomically. So it's just a factor of getting the numbers down. The Scottish Government announced this week that we are going to build capacity to allow Scotland to do 1,000 a day. So if we get down to positive cases around there, now the genomic sequencing, we can't build it tomorrow. It's a medium-term challenge to get that up and running. And remember, it's not just a machine. You also need trained staff. You need resources to keep it going. It's quite a complex laboratory exercise. It's in addition to the yes-no PCR test, though, remember, because it takes much longer. So the PCR test takes 24 hours. The genomic testing can take some days after that. So it doesn't necessarily help you deal with the positive case when you're presented with what to do with it. So that's why we use other intelligence like where did you travel from, what did you do, and that's how we decide whether to do enhanced contact tracing, whether to do whole household isolation, all those other things we've grown to get used to. And that's why just now, high-risk countries like Brazil and South Africa, if you've come from them, even via other places, we do extra stuff. We do enhanced contact tracing. So we contact trace contacts of contacts, and we ask you to do the genomic testing on that sample. So the genomic testing is an extra layer of protection for us as we come out the other end of this, because it's important to remember that the European average vaccination rate is 7%, and France's target for the beginning of July is 10%. So the world is not vaccinating at our pace. Almost nobody is vaccinating at our pace. So we're going to have to be very, very careful, even if we get incidence low, about what we do with people who travel in.
Okay, that's very helpful. Thanks, Convener.
Thank you, John. Our next questions come from Maurice Corrie. Maurice.
Convener, thank you. First of all, Cabinet Secretary, may I wish you well in your retirement, and no doubt we'll bump into each other in the Kyles of Bute or around Collintrive or wherever in Argyll and Bute. So happy retirement there. I hope you enjoy it. And thank you for all the input you've done for all this work over COVID. We do appreciate it. First question to the Cabinet Secretary. What contact has the Scottish Government been having with ship owners and the ship management companies based in Scotland to undertake regular testing of their ship's crews? And this is a follow-on from Beatrice's question.
Thank you for your kind wishes. I have to say that I will have to get information on that, about what discussions have taken place with ship owners and ship crews. I am not cited on that at the present moment, so we'll get you the information from the people who are having those conversations.
Right, thank you, Cameron. Second question is for Professor Leach. Professor Leach, are you happy with the speed and strategy which the First Minister is now opening up Scotland nationally, as announced on Tuesday?
I am. It's a set of choices, and let's not pretend it's anything other than that. And in earlier questioning, Mr. Russell described the attempt to bring the whole of the mainland down to level 3, with which I agree. The cost of that is, or the benefit of that, is you can remove travel restrictions, because it's not quite so important from a public health perspective to keep everybody in their own local authorities. If you do more regional-based reductions, then you end up needing travel restrictions. So it's not that there isn't an easy path. There isn't a risk-free path. This path appears to me to get the correct balance between that risk and prevalence. But the red line for Gregor and the Chief Nurse and I is we have to review. We have to have the ability to look at the data on an ongoing basis. And I realise how frustrating that is for everybody, and I realise how difficult it is to not absolutely have clarity if you own a gift shop, or if you own a pub, or you own a soft play centre. But that clarity is impossible to give if you don't let us review the data.
That's fair enough. I understand that, and I'll accept that response. Thank you, Professor Leach. And the final question is for Dominic Munro. Mr. Munro, in respect to the hospitality sector, what difficult issues have you been addressing to assist the hospitality sector in respect to your work on the exit strategy?
So that's a good question, Mr. Corrie. So we've been in engagement, not myself directly, but colleagues who work in the hospitality part of the Scottish Government with the sector on a regular basis. And we've been considering factors such as opening times, how best to mitigate transmission risks within hospitality premises, and so on and so forth. So what we've set out at present in our plan is our best judgment on how to safely reopen the hospitality sector at the appropriate stages of our exit strategy. I think alongside that, of course, and this goes for every sector, it is incumbent on premises to take all the necessary mitigations and other public health measures that we've discussed with them to prevent the spread of transmission when they open again. So we have maintained significant dialogue with the sector over this period. We understand how difficult this has been for the sector as a whole over this period. But fundamentally, the challenge that we grapple with is that coronavirus is a virus that spreads when households come together within settings, and that is essentially what hospitality settings do. They bring people together. So, as Jason has mentioned, there's always very difficult choices about how you balance risk on the one hand, but at the same time try and minimise broader harms, and in this case, in particular, the broader economic harm to the hospitality sector.
No, that's fine. Thank you very much indeed, Mr. Rowe. And back to you, Convener. Thank you.
Thanks, Maurice. We turn next to Annabel Ewing. Annabel.
Thank you, Convener. Good morning, gentlemen. And I would also wish to thank Mike Russell, the Cabinet Secretary, for his outstanding public service and his dedication to improving the lives of people in Scotland. And I know that he has a further contribution to make, but perhaps in a different role. Turning to the issues at hand this morning, Picking up on the international travel issue, I know that we have discussed that in some detail this morning. My question is, given the advice that is in place in Scotland, what would be leading the UK Prime Minister to be proposing a May 17th lifting of international travel restrictions? What information would they have that we don't have? And in light of the vaccine supply shortage issue that has been discussed already this morning, is that likely to have any impact on the UK government's timetable in that regard?
First of all, thank you for your kind words. I really could not and would not put myself in the position of deciding or postulating what leads the Prime Minister in anything, and indeed I wouldn't want to go there, frankly. I can only speak for the policy that the Scottish Government has, and the Scottish Government is entirely clear, and the First Minister has been very clear, that the issue of non-essential overseas travel is not on the agenda at the present moment, and cannot be, given the risks and dangers that would introduce. And Jason has just been very clear in a previous answer. If vaccination is one of the major routes out of this, and there is a lower level of vaccination in other places, that becomes an additional issue over and above the issue of the variants that can be imported. So in those circumstances, we are not talking about non-essential international travel being back on the agenda at this stage. What the UK government talks about is for the UK government to talk about. It would not be the position that we would be in. And indeed, as this unfolds, I'd be surprised if that was not also a view that gained strength and credence elsewhere.
I thank the Cabinet Secretary for the answer. I mean, I wonder where everybody's supposed to be travelling to in light, indeed, of what has been said, where we are seeing COVID on the rise again in continental Europe, and indeed the vaccination stats in many countries being what they are. I don't know exactly where everybody is supposed to be going on May the 17th, but we shall wait and see. On the issue of hospitality, which has been raised, obviously in the last few days we have heard many interviews with very many frustrated business owners in the hospitality sector. And just perhaps for Professor Jason Leach, I mean, one issue that is frequently prayed in aid is that they say that, their premises are not the cause of any transmission of COVID, that they're much safer than going to the supermarket, for example, or whatever. And from looking at the science, can Professor Leach maybe just clarify matters from a scientific perspective as to the position? Because I do find it frustrating when I'm listening to these interviews that we're not really getting to the bottom of the science here. Professor Leach.
At one level, the science is... thank you, Ms Ewing, and good morning. At one level, the science is straightforward, and at the other, it is frustratingly challenging. The virus moves from person to person when people meet. That doesn't matter if it's in a house, in a restaurant, or in a supermarket. It has opportunity. It requires time as well as opportunity. So the longer you are together, the easier it finds to do that. And the less ventilation there is, the easier it finds to do it. So therefore, indoors worse than outdoors, etc., etc. There isn't a single sector in the country who believe transmission happens in their sector. And if I were in charge of a sector and trying to maintain its businesses and trying to maintain it economically, I would almost certainly be on the TV saying exactly the same thing as them. The challenge for us as public health advisors, and then even more challenging for the decision makers, is to try and open each of them as safely as possible. That is partly down to their mitigations, which I have no reason to believe aren't robust and helpful, but it's also about sequencing. And it's what Mr Russell said right at the beginning in answer to a question. You simply cannot have everything at this level of incidence. So you have to make choices. And you can see that around the world. You can see Italy reclosing cafes, restaurants and tourism, having opened. And we've been through that once. We don't want to go through that again if we can possibly avoid it. So therefore, it's about sequencing that opening with business support, which isn't my job, but people shouldn't be penalised for having to close their businesses, for business support, and then monitoring the data over time to see what happens. And I don't blame any industry for asking for earlier opening, not in any way, as long as they do it politely, which most of them do. But they shouldn't either blame me for the public health advice we're giving to try and protect the whole population, not just their individual industries.
I thank Professor Leach for the answer, and I would absolutely agree 100% with his last comment. Everybody understands the frustration if you're trying to run a business in that sector. It's obviously really, really hard times, but equally we all want to get out the other end of this, so we must find a way through this. So one last brief question, if I may, my last 2 minutes, convener. We've talked a bit about the booster, Jag, this morning, and I just wanted a brief clarification. So I understand that could be done along with the annual flu vaccination, and we say autumn, does that really mean November, December, January? Autumn for a civil service, I know, starts kind of at a different time from the rest of us. Professor Leach.
That would be for Mr Munro to answer when autumn begins in civil service terms, not for me. So in short, we do not know what booster vaccine will mean. Most of the smart immunologists, the mainstream view appears to be that in light of new variants and in light of the length of time immunity appears to last, we will need a booster vaccine at some point in the next 12 months. In some people, that may well be with the flu vaccine, but we'll have to do trials to make sure you can give those two things at the same time. And we may even, some drug companies may even combine the vaccines into one vial, and therefore it will make it much more logistically straightforward for us. But that requires scientific trials to make sure we can do that. We'll also need to look at whether you can switch the companies. So if you've had AstraZeneca, could you then have Moderna? If you've had Johnson & Johnson, could you then have Pfizer? Probably, but we need to do the trials to make that certain. My best bet would be that leading into winter 2021, we will probably be on some form of booster vaccination programme, maybe just for the vulnerable, maybe for the whole population.
Okay. Right on time. Thank you very much, Professor Leach and Cabinet Secretary. Thank you. Yeah.
Thank you. And our final set of questions come from Emma Harper. Emma.
Thanks, convener. Good morning. It's very interesting so far. I have a couple of questions about personal protective equipment and review of that. We've learned a lot in the last year about how the virus is transmitted, and we had droplet infection was originally what we were worried about, and it seems that aerosolizing is obviously a concern now, and there doesn't seem to be an international consensus on what aerosolizing generating procedures are. And I'm also interested about activities that aerosolize, so singing, coughing, breathing, even close proximity working in care homes or care at home and acute care. And my concern is that surgical masks might not be the most effective in protecting people who are caring for those that are COVID positive or symptomatic. So I'm interested to hear about what work that's been done to review personal protective equipment like FFP3 type masks, and so that the wearers continue to be protected.
I know that the Chief Nursing Officer has been engaged in this, and I'll ask Jason to update us. I'm sure he can.
Yeah, I can't update you as well and as intelligently as the Chief Nurse could. So it may be that once this committee reconvenes, when we're still in some version of this, you may wish to hear from her. I can get her to write. I can ask her to write specifically. The summary answer is that the 4 chief nurses across the UK hold the ring for this exact question for us. They have individual in-country processes with experts, with infection control experts, with those who are in the front line, the unions, etc. And then there's a UK-based version which does that on behalf of all of us. And that's kept under constant review. We've changed the PPE instructions and guidance a few times during the pandemic. The present position is we've just adjusted inside healthcare environments again to increase the use of face coverings, but we haven't adjusted the brand or the level of face covering because the evidence suggests that's not necessary. We keep that under constant review, and if it changes, we will change our advice. The only other thing I would add, Ms Harper, and you know this from the job, is an FFP3 mask is a horrible thing to wear. It's not comfortable. Wearing it for long periods is very uncomfortable. And that's not a reason not to give it to people, but it's why we use it in places where aerosol generating procedures in particular are a risk, like dental practices or intensive care units, where we are almost deliberately creating aerosol generating procedures in order to give people healthcare. And we try and keep that to a minimum in other places. Your first point, which was the definition of aerosol generating procedures, is also a good one, kept under review by the MHRA, by others, by NICE. And in Scotland, we developed the one for dentistry, which has then gone round the world to all the global chief dental officers and has been used all over the world to give safety advice to dental practices and dental schools in particular. There's been quite a lot of work in there about some things right on the edge of aerosol generating, like food tubes for those in additional special needs schools, etc., etc. So there is a mechanism for keeping all of that under review, and all of those lines lead to the chief nurse, who then advises the government.
Okay, and thanks. And it has been suggested to me that we should be looking at aerosol generating activities as well. So just like activities of daily living, close proximity care, that's another thing where if somebody is symptomatic, you're not actually doing a procedure, so you're not intubating, you're not making them cough like a physiotherapist would when they're doing chest physio. So is there a consideration that would be given to look at activities that like close proximity personal care, for instance?
Yes, and that's why there are layers of protection in that conversation as well. So I think there's two categories. There's the close personal care that you described, and that could be hairdressing, or it could be social care provision in a house or in a care home, which is of course a house for many, and PPE, hand washing, ventilation, all those things, the general mitigations in place are all very, very helpful to keep that to a minimum. And you need to work hard to get the virus to infect you in that kind of environment. So you can protect yourself to a great extent in there. There's then a second category, which is, forgive the shorthand, the more social element. So the interaction we would have talking to our families, the singing in a choir, the singing in a church, or wherever else. That is a separate category, again needs general mitigations, and over time, as incidence falls, that will become much safer. Because that just now, the risk there is a factor of the number of people who have the virus. If we get the number of people who have the virus down, then you can begin to reduce those kind of distancing protective measures for the general population.
Okay. Just have a final question, Convener, if I may. And Jason, you talked about ventilation, and ventilation has seemed to gain more importance. And I'm thinking about ventilation as well as air filtration. There's been work done by Eric Fiegelding in America looking particularly at ventilation. Is that something that we could be doing more work around as well?
Again, the chief nurse and others at the what we call RHI, the Healthcare Associated Infection Group, chaired by Professor Jackie Riley, look at many elements of that. I don't know that specific piece of work. She may well know it. We do know that ventilation simply moves the droplets away. That's what it's doing. It's just moving the droplets around so they don't settle and infect you. And it stops surfaces getting quite so covered by the infectious agent. So ventilation is good. Air filtration, a little bit more controversial. There's quite a lot of offers in the market that don't do what they suggest, but that doesn't mean we shouldn't do air exchange. We do that in operating theatres all the time, and there are places in which that might be more helpful. But the secret in a classroom, in a restaurant, or in a nursery is to open the windows and just let the air move.
Okay, thank you. Thanks, Convener. That's me.
Thank you, Emma. I believe we have a supplementary question from Mark Ruskell. Mark, would you like to ask a supplementary?
Yeah, thanks, Convener. It's just a quick one. It was on the back of what Jason Leach said earlier about workplace testing. I think you said that any workplace could request asymptomatic testing. I just wanted to clarify that. And if I was running a hospitality business, for example, and I wanted to get asymptomatic tests for staff, is that something that you could request right now, or is there a particular set of conditions to fulfil before you're able to get access?
You could request it, but the decision-making process would be slightly more than just on demand. So there would have to be a reason for it. Every clinical test has to have a function, and that may well be something that the local public health or environmental health people could do for you, but you'd have to understand the limitations. You'd have to understand what it does, what it doesn't do, and what it certainly doesn't do to the mitigations that you would have to have in place around your workplace, around your staff, etc. And there are ethical reasons in there about forcing people to have them, so we'd have to do it in the round. But yes, if you think there is a reason for you to have asymptomatic testing for your workplace, your local public health team will be delighted to talk to you about it.
Thanks.
Thank you very much. And that concludes our consideration of this agenda item. And can I thank the Cabinet Secretary, Professor Leach and Mr Munro for their evidence this morning. I will now move on to the third agenda item, which is consideration of the motion on the subordinate legislation that we have just taken evidence on. Cabinet Secretary, would you like to make any further remarks on the SSI before we take the motion?
No.
I now invite the Cabinet Secretary to move motion S5M 24303 that the COVID-19 Committee recommends that the Health Protection Coronavirus Restrictions and Requirements Miscellaneous Amendment Scotland No. 2 Regulations 2021 SSI 2021/117 be approved.
Moved.
Any member wish to speak on the motion, and if so, could you please indicate this by typing R in the chat bar now. I note that no member wishes to speak on the motion, so can I now put the question on the motion? The question is that motion S5M 24303 be agreed to. Does any member disagree? And if so, please type N in the chat bar now. I can confirm that the motion is agreed to. The committee will publish a report to the Parliament setting out our decision on the statutory instrument considered at this meeting in due course. And that concludes our consideration of this agenda item and our business for this meeting. But as this is our last committee meeting before the election campaign recess, I would like to express our thanks to a number of people. First, can I use this opportunity to thank both Mr Russell and Professor Leach for the constructive way that they have engaged with this committee and for making themselves available every week to give evidence, as well as promptly following up queries that have been raised at meetings and thereafter. This has been greatly appreciated, and can I wish the Cabinet Secretary well in his retirement as an MSP in particular. In addition, can I put on record the committee's thanks to our advisors, Professor Linda Bald and Dr Helen Stagg, who have provided the committee with weekly briefing. Their expert advice has been invaluable in supporting the committee's scrutiny work. I would also like to take this opportunity to express the committee's gratitude to all our support staff in the Parliament, especially our clerks and researchers, whose help has been much appreciated. And finally, can I thank my colleagues, the committee members, past and present, for all their contribution to the COVID-19 committee's work. And I now close the meeting. Thank you.